after our session. Alrighty. So welcome everyone to a special Friday edition of our Lunch and Learn session. Lunch and Learn is an initiative of the Patricia A. Tejan Teaching Academy to promote learning and connection in the larger Nuvance Health community. We feature innovative speakers from within Nuvance Health and friends of the Academy across the United States and the globe on topics related to medical education. And these monthly sessions are usually held every fourth Wednesday at noon. They are recorded and posted to our website within a week or so. We're updating our webpage, so there may be a little bit of a delay. If you don't see it posted, just send me an email and I'll be happy to send you the link. So please remember that this is a lunch and learn, so feel free to eat your lunch. We would love to have attendees keep your cameras on if possible. It's fine. We know what it looks like to eat a lunch. Don't feel self-conscious about that. If you'd like to receive CME credit for this session, please make sure that you logged in through EADS, and in a minute I'll put that link again in the chat. Just a quick word about the Teaching Academy. The Teaching Academy was formed in 2021 with the purpose to create a home for the community of interdisciplinary, interprofessional clinical educators at Nuvance Health. We currently have 17 enrolled scholars in our second interprofessional cohort, and applications for our 2023-2024 cohort will go live in spring, probably late March. So if you know someone who's interested, or if you yourself are interested in becoming involved with the Teaching Academy, please let us know. We also hold office hours one day each month at each of our hospital locations, and we'd love to connect with you in person to say hello, grab a cup of coffee, or share a bite to eat. So if you'd like to connect with us, please send an email either to me or to teachingacademy@nuvancehealth.org. All right, now to introduce today's speaker. Dr. Janel Coral is Associate Dean of Medical Education at the University of Nevada, Reno School of Medicine, overseeing the 4 years of the undergraduate medical education program. She focuses on curriculum as a social structure to enact innovation in the learning sciences and competency-based education. Her research has been published in the Oxford Textbook of Medical Education and top peer-reviewed journals. It has focused on developing trainees' expertise in ill-structured domains, and that includes the use of analytics and human factors approaches to bring about solutions in a systems context. She has won awards for curriculum design, simulation, and educational leadership, including the Amy Aspire Award for Faculty Development. Dr. Corral is currently an executive board member and site lead for Best Evidence Medical Education, which is an international collaboration of the Association of Medical Education of Europe. She's the chair-elect of the Western Group on Educational Affairs in the Association of American Medical Colleges. She's a past steering committee member of the Group on Informatics Resources and the Academy's Collaborative in association with the Association of American Medical Colleges. And finally, she's the co-founder of Alentra, a learning management system in use in 20 medical schools worldwide, and a major contributor to the open source virtual patient project, Open Labyrinth. It is our pleasure to have Dr. Corral join us as a distinguished Lunch and Learn speaker. Please join me in welcoming Dr. Janel Coral and her talk, What's New and How We Use It Well in Clinical Education, Artificial Intelligence and Virtual Reality. Dr. Coral, you can go ahead and share it. Yep, perfect. That looks good.
Wonderful. Well, welcome everybody. Thank you, Beth, for that super kind introduction. But folks, what she missed out in saying there is that I'm a pedagogical troublemaker. That's the true job title that I'd love to have. And so what that means is that you are in the hot seat in this presentation, not me, which is my hopefully funny way on a Friday of saying, let's interact with each other. Let's not just sit here in silence. This is about you and what you need to be a great educator. So let's start with that. I'd love for you to come on the microphone or come on the chat and tell me, when it comes to AI and VR, what do you most hope to get out of today's session?
Hello, my name is Mirgani Ali. I'm the fourth year chief here at the Interim Master in Residency Program at Vassar. The main aim for me is to see how we can incorporate AI into medical education. I know a lot of centers are trying to incorporate AI in patient management, but it's interesting to see how we can involve that in artificial and virtual reality into medical education.
Wonderful. Awesome. So some high level answers to start off. Learning analytics. You'll see the AMA has a webinar coming up on November 28th on what they're calling personalized education. So a lot of the big people in medical education, learning analytics will be giving that presentation. Another answer here for us, and this foreshadows later on this morning, is we just really need to rethink how we're training our future colleagues in light of AI. So some foreshadowing for later. Anybody else? Any other things that you really want to get out of today?
Feel free to unmute or chat in your response, and I can monitor the chat as well. I think we have a lot of like sponges just like ready to absorb here. Probably a lot of curiosity
Awesome.
about what's
Okay.
possible.
Well, let's get into it. Look, folks, I always start by telling you the answer key. So here's the answer key. AI and VR are fantastic, but we have to design it well. So we have to resist the law of shiny objects, which is there's a lot of new, great, sexy things out there in VR in the AI world, but it'll lead us astray if we just think, hey, let's pull stuff off the shelf and go with it, right? Just because it's new. So if we really care about learning outcomes, we have to think about the learning sciences. So I love that you're part of an academy. Today, you're going to be applying, what are great learning objectives? What is constructive alignment across a learning objective to a teaching event to an assessment event? You're going to be applying Bloom's taxonomy as we go through VR and AI. So put your thinking hats on as we go through this, and let's buckle up and head into virtual reality. So as we look at VR, we probably want to start with a definition. What are we even talking about here? So we could just talk about the headsets, but it's actually a continuum. It's everything from augmented reality, which can be your iPad or your cell phone hovering over something in the real world and the screen displaying something else. It could be virtual reality with the headset, or mixed reality, which even involves a physical and sensory experience. So what's an example of augmented reality? One of them is PerSim. And by the way, you're going to hear me say a lot of company names throughout this. My full disclosure is that I have no affiliation with any of them. PerSim is, as you can see, EMTs, paramedics can take this on the truck. They can pop on that VR headset and see the patient having a seizure, something that they wouldn't be able to practice even in a great way in a sim center with a mannequin. But while they've got downtime on the truck, they can put this on and do some continuing professional development or just learn and expand their current practices and refresh. In the VR world, we actually have two flavors of VR. There's this world of VR that's 360-degree video. And this means that it's actually capturing the real world and putting it in to a VR experience. Or you can pay a lot more money and work with animators to create an animated type of VR. Now, you can imagine in a simulation continuum, sometimes the real world is what we want to capture. Other times we need to augment what's happening in the VR world so that we're capturing the real world and the thing that we want to teach. We'll go into some examples here on the next couple slides. But here I'm going to pause and tell you how mixed reality almost cost me my marriage. How many of you have been to Disney World or Disneyland and done the Star Wars mixed reality experience? No one? Okay, well, let me tell you folks, for $38.95, my husband, a huge Star Wars fan, says, let's go. Grandma and Grandpa have got the kids. Let's go. So I think, all right, and to be honest, folks, I was a skeptic on what mixed reality really could do. And here's what happened. We put on the headsets. They make you sign in, and you get a wristband that's got a QR code, and it's giving you an identity. So it turns out we were given identities that we were part of the resistance in Star Wars, and we were to dress up as stormtroopers and sneak into one of their bases and capture back one of our own. Well, they put this VR headset on you, this backpack. The backpack shakes every time that you're shot in the whole experience, but it was more than that. We then put on the headset, we come into this room, and then door closes behind us. And I swear this room was maybe only as big as a closet, but we went light years in our minds. They have you sit down on a bench, and the bench inside your goggles, you're actually inside a stormtrooper ship, and you're dressed. When you look down, you look like a stormtrooper. And as the ship, rumbles, your bench shakes, and then you stand up, and then another door opens, and you realize you're on a skiff going over a hot lava field, and you can feel the heat, you can smell the smoke. You're immersed in this mixed reality experience. But I was still suspending my participation in this until the shooting started. And when the shooting started and your backpack goes, and my husband was yelling at me like, hey, let's go back to protect ourselves. Suddenly I was really getting into this whole scenario. And I got so immersed into it that I don't want to spoil this for you if you ever do this experience, but let's just say a very prominent member of the stormtrooper regime comes out with a lightsaber in this whole experience. And that's when I say, that's it. I'm out. I can't do this. This is too scary. I'm out. And I turn and I walk. And my husband's like, we were in the middle of a firefight and you walked out on me? What kind of marriage is this? So hopefully that brings you some laughs and some giggles there in the background, folks. Jose and I are still happily married, but I learned when it comes to a firefight, I better stay back to back with him to the end, no matter who walks in the room. So let's translate to our own world, health professions. What are some examples? And this is where Bloom's taxonomy comes in. I want you to think as you see these next examples, are they a knowledge type of thing? Are they an analysis or synthesis type of thing? So in the VR world, you know what? Anything in technology with medical education, everybody starts with the low-hanging fruit, anatomy. So this one, Organon, you can see is very drawing animation based. So that's great because it allows us to create a lot of different anatomy, and you can pick and dissect, etc., right? You can't do that if you were doing 360 video VR. So there's an advantage to using the animation side here, yet we did a study when I was at University of Colorado. I was in the School of Medicine, but I partnered with a School of Dentistry that had started a whole VR lab. We had the dental students train on this particular VR product, and we split it was randomized control study. Half the class trained on this, half the class trained on the models in the anatomy lab. And then we looked at the results on the knowledge quizzes over the course of the semester. And what we found is the students who did the VR anatomy had a great time. They thought it was cool. However, they had lower knowledge scores. Why? Because the distances in the animation are distorted compared to actual anatomy. So when it came to doing the same quiz as the rest of their class, they hadn't studied on actual anatomy of actual patients, and so their actual knowledge base was off. So you could say, all right, well, let's do one better. Well, here's a company that uses actual MRI scans, layers them all together, and then adds in color and depth using graphic designers. So you could say, oh my gosh, like that's so much better because we're using actual anatomy, actual radiology in all of this. So think about, where would you put that on a Bloom's taxonomy compared to the one before? You might still say they're both at knowledge, but you might say that this might be a little bit higher. So hold on to that thought, and let's go one layer again. Here's physiology of the eye. So you're seeing a cartoon version of the eye, right? An animation. But what they've got here is flashcards. And so they're teaching you something, but asking you to learn and recall and quiz. Here's yet another example. This is Oxford Sim from the University of Oxford. They have, I don't know the latest count, but when I talked to them a few months ago, 22 adult cases and several pediatric in the works. You can use this in VR or on your computer screen, and it's a full virtual patient case. So you go from history to physical exam to investigations, and you can see there that you have a colleague in the room that you can say, hey, can you do the blood draw? Can you do the urine sample? Can you bring up the investigation results? And so it really is like being in the sim center, but it's in a pair of VR goggles. And if you think about where this fits on Bloom's taxonomy, you might think, well, that's a little bit more than knowledge, and you wouldn't be wrong there. But where does it fit? What's also great about Oxford MedSim is that they have really deep analytics, just like being in the sim center with a mannequin type of simulation. So you can really get some in-depth insight at the end of the case about your reasoning, where you went right, where you went wrong, why you were wrong, your time on the case, how much time you spent, your high value care choices and investigation, and so forth. Another aspect of VR though, and this is now using that 360 video VR, is could we help build empathy? So here, if we have macular degeneration, how much do our trainees understand how hard it is on our patients to go through life? So here you're seeing, when you put on the goggles, you're the patient and you're seeing how hard it is to be them in life. They're missing their birthday cake. That's what's behind the black occlusion that you see there. And so what you do when you put this on, and Embodied Labs has several scenarios that they've recorded and done for different pathologies. You wander through the day in the life of this patient, and that helps the students debrief afterwards on like, oh, wow, I wasn't thinking about this, that, and the other thing. You can also wind in social determinants of health in some of their empathy training. And so it's another way of looking at the same type of technology, but for accomplishing a different learning goal. Our colleagues at the University of California, Irvine, Julie Yum and Warren Weichman said, you know what? We have a problem with our med students in terms of empathy for non-English speakers. So they created a completely Vietnamese outpatient clinic. And so what you see here is their $30 dummy that they put together. They call it the Scarecrow, and a $500 360 VR camera. And they enlisted their students to create this clinic where nobody spoke English, just to help students develop that empathy for, if you're an English speaker and no one around you speaks English, how are you navigating the healthcare system? And they've debriefed this activity with their students in terms of seeing their empathy improve on validated scales of empathy. And it's also increased their students' communication skills as they head into the clerkship phase. So what you've hopefully seen across this quick survey of examples is that depending on the technology, you can accomplish different learning goals, but not one VR experience is really built to accomplish everything. And so now it's over to you. I'll give you two examples. The anatomy VR one with the flashcards, so the physiology of the eye that had the flashcards, where would you put that on Bloom's taxonomy? Is that a knowledge, understanding type of thing, or is that more like a synthesis evaluation type of thing? Come on the mic and share your thoughts.
Hi, Robert Stork. I would say that's more of an understanding because it's definition matched. So it's my, I already have the base knowledge and I'm just applying, not, I won't say applying because that's later on, but showing my understanding of it.
Absolutely. Yeah, no, I would agree with you on that. That's very insightful. The flashcards are more of like that recall, understanding, demonstrated knowledge piece. Okay, so let's look at, oh, sorry, hop on the mic.
Yeah, it does have some application aspect of it, right? Because it's practical, you have the visual and you put the cars together. So you can actually bridge at least into this application part. Definitely is no analytic and there's no synthesis there.
Absolutely. Yes, I love that. So let's look at example number 2. Think about that Oxford MedSim where you have a patient case and it's got feedback and embedded analytics for you. Where would you all place that on Bloom's taxonomy?
I personally think it's probably in the analysis side of it. Not sure if that sort of learning still actually gives you the capacity to synthesize, because it's still like sort of, it's a reflective interaction, right? It's a question and an answer. Even if there is some sort of a scenario involved, I think you're still in the maybe analysis, but not yet at the synthesis level. My opinion.
Yeah, I love that. It's true. There's parts of going through a patient case that are absolutely about analysis and synthesizing that information to come up with the next answer so that you can proceed in providing care.
I think there was another answer, maybe. Morgani, were you gonna say something? It looked like you were about to
Yes,
speak.
yeah, I agree. It's more towards the top of the pyramid rather than the anatomy VR cases. There's more, analysis and synthesis of information that you're seeing via VR.
Absolutely. And so hopefully you can see that, look, there's a lot of shiny things out there, but how do we really get to our learning outcomes? We have to pick the thing that's going to at least get us there. We have to do that alignment between our learning objectives and the type of teaching tool that we're going to pick up. So we'd pick up Oxford MedSim if we're ready to help students synthesize their knowledge base and start doing that analysis and application and synthesis. But we might pick up that physiology of the IVR if we were really doing some level of knowledge and understanding and recall. So let's get into it though, because there's more than just grabbing something off the shelf and throwing it at our learners. So what you'll often get with VR is exactly this. That was super cool, Dr. Corral, let's do more of that, right? But med school runs like a freight train and I want competent students graduating. So I want more than super cool, right? And so let's look at some of the literature out there on what's going to really impact learning. So here's a great study, and this is one of our classic, designs, right? When we don't know the literature, we always seem to pick what's that new technology versus the thing that we've always been doing. And so this was an example of students doing the same anatomy learning in VR versus traditional dissection. And then what you see in, the 7.25 out of 10 versus the 6.87 out of 10, that's their quiz scores. So a knowledge-based quiz score at the end. And you can see that the p-value, not that great. So what's going on in this type of study? Well, more than it's easy to conclude, well, this really didn't work. We might as well just do dissection or keep on what we're doing. But it turns out there's a whole website I want you to know about called the No Significant Difference Phenomenon. And this happens in educational technology, in fact, for decades. So what this website has done, it's your meta-analysis place for everything in education technology to see, does it work or does it not? So whether that's an 8-track tape, a laser disc, a CD-ROM, a simulation mannequin, it's all here. And the answer is right in the website name. When you compare the new technology to what we were traditionally doing in a non-technology environment, you're always going to end up with no significant difference. Now, in clinical medicine, we would then say, well, if that was a drug versus drug comparison, why would we even adopt the other drug? We wouldn't. But in education, we say, wait a second, we probably had an apple versus orange comparison. And what we need is an apple-apple comparison to understand if there really was a learning outcome difference. The other thing to think about is that we don't necessarily throw out the technology. We just need to we need to determine how to design the session so the technology might be effective for learning outcomes. So let's get into that. Clark and Kozma had a massive debate through the 80s and the 90s. These are two giants in the ed tech world. And what you see cited at the bottom there are just 3 of many articles where they went back and forth at each other over, is technology the thing that changes learning outcomes, or is technology just a vehicle for delivering content? And the conclusion of their debate in these journals was that any technology you pick up is just a vehicle for getting the same material across. And then we have to decide, do we need a truck or do we need a Porsche? So it really comes down to the design of the experience. So let's look at some of these studies. Now let's look at VR versus augmented reality, right? So now we're doing more of like an apple-apple comparison versus what we see, just on a tablet, your iPad type of thing. So not a huge sample size. And what they did was they gave students the same anatomy experience, but in 3 different technology modalities, and then gave them a quiz. And you can see that, guess what? No significant difference. So there was no difference in just tech to tech to tech comparison. But what did we learn here? We learned some qualitative stuff. VR can be a disorienting experience because of the processor speed of the VR headset. So that's where you get the dizziness, the headaches, the blurred vision. The VR headsets in this study, 2017, are completely different than the VR headsets we have today. The ones we have today, the processors have gotten faster and faster. And so you are seeing less of a dizziness, headache, etc. type of side effect. It means that your students can wear the headsets longer, but not necessarily like for an hour. Now, who you see cited at the bottom here, Richard? Yeah, sorry, hop on.
Was it the faster was better? Not the other way around. So the faster the processor and the images that are projected is better, not worse.
Correct. The faster the processor speed, the less dizziness and headaches you're going to see in your participants, your learners.
Thank you.
Excellent question. Richard Mayer down here at the bottom. Folks, if you don't have a summary of the 12 multimedia principles by Richard Mayer, you are missing out as educators. You can find them all over the web, or you can drop about $150 and buy the Cambridge Handbook of Multimedia Design that he's the author of. It's a thick telephone book-like type of book. Long read, but there's also a YouTube link that I'll send to Beth after this, and it's the best 13 minutes that you've spent seeing one of your peers at Rush Medical School in Chicago take his classic PowerPoint slides, apply the multimedia principles to them, and you see them completely transformed. And he does this 2 times in 13 minutes with 2 different presentations. And so Mayer really tries to get into the technology and understanding, what is that design of the technology that's going to get the learning outcomes that you want, right? He's always thinking about cognitive load, germane load, extraneous load. And so that's what this study is about. He compared the same VR experience, but what you see in segmented VR is you got a headset for 5 minutes, and then you got 10 minutes to consolidate your learning and do a quiz. You then put on the headset again for 5 minutes, do some learning in the VR space, and come out of VR, consolidate your knowledge, and do a quiz. Continuous VR, as you can imagine, is put on the headset for 15 minutes and then do the same quizzes. So let's pause here. What do you think was the better one? What resulted in the better learning outcomes?
I would say segmented.
And why is that?
Because I think the fact that they can repeat, so they get a piece of information, they can repeat it, they have to synthesize this and make an answer, it probably makes them fixate the information better.
That's an excellent unpacking of segmented and a good defensible hypothesis. Anybody want to go for continuous VR?
I would say continuous might be more immersive for them, so they might benefit from the continuous VR in that way.
Excellent point. Yeah, some things take a while to learn. You can't just learn it in 5-minute chunks. Well,
yeah,
this is what
the devil's advocate, and they may be having sort of the bird view of the project or the situation may be still good. I guess it recapitulates the stuff. So I guess you have to tell us which one was it.
So in this case, again, they're learning anatomy. That's the picture on the left. It wasn't that particular anatomy, but again, low-hanging fruit in med-ed is always anatomy, so VR of anatomy. You're absolutely right that what worked was the segmented VR. Why did it work? Because our short-term memory can only handle the rule of 7, right? 7 plus or minus 2, so we can only handle 5 to 9 chunks of information at any one point in time. And then what the segmented design was doing was allowing the students to consolidate before they went on. Now, the truth is you're both right. If you were trying to learn something like a full patient scenario, like Oxford MedSim, you could imagine that you need more than 5 minutes, right? And then to consolidate your knowledge. But again, it goes back to our core point today. You've got to understand your learning objectives before you just grab that shiny technology off the shelf. The physiology of the eye works for a segmented VR. Oxford MedSim works well for continuous VR. But now you've got to think about what is the processing speed of the headset and how long is your learner spending in there so that they're not getting dizzy and nauseous and everything else. So it turns out that when you also go a little bit deeper, segmented VR resulted in better post-test scores, but neither modality increased engagement, motivation, or interest. Wow. So what's going on there, right? So we think we're going to take this sexy thing off the shelf and give it to our students, and they're going to say, that was cool, Dr. Corral. But it turns out they would rather be in the anatomy lab. You know, their first patient is more exciting to them than VR when it comes to anatomy learning. So Richard Mayer, undaunted, did this other study. He